welcome to today's research seminar brought to you by the Department of English and Communication at the Hong Kong Polytechnic University. Today's speaker is Professor Stefano Occhipinti, who, if you don't know, has recently joined our department. He has a background in experimental psychology, and his research interests evolve around a number of core issues, including decision-making in the healthcare process, the social context of men's health, cancer survivorship, and the stigmatization of illness. Using both quantitative and qualitative techniques across his career, he has published in journals like Health Psychology, the Journal of Clinical Oncology, and very impressively, The Lancet. So without further ado, I pass over to Professor Occhipinti.
Thank you, Jamie. Thanks a lot. That was great. Excellent name pronunciation too. So good evening all, or indeed, if you're in other parts of the world after our most recent conferences, we got used to saying good morning, good evening, wherever you are. So it's evening here, and I'm here to talk to you about cultural difference in stigmatization. I really should say in stigmatization about health. And in particular, we're wanting to kind of look at the role of a construct called moralization. And these things matter for various reasons that I'm going to be going through now. Of course, we begin by thanking those who have funded parts of this research and those who have taken part in large chunks of this research. There they are on the screen now, including some of our own folks from PolyU. So thanks to all of them. Let's begin simply. Like, what is stigma? And I'm going to give you a more involved, I guess, outline of the process later in the talk, but just to sort of start with something, because we all know what stigma is in some sense. We all have a gut feeling or an implicit sort of definition, and in fact, definitional concerns are kind of important in stigma, because every now and again people realize that we're all talking about often somewhat different things. But let's just start with the idea that stigma is a denigrated group identity, and it leads to avoidance and negative outcomes. Both those things matter. Someone responds negatively to you and avoids you because of your individual attributes. They just dislike you. They're not stigmatizing you. To be stigmatized, it needs to be on the basis of you belonging to a group, a target group that is in some way marked or tainted, a stigmatized group. And it's not, pardon me, it's not enough to just not like you. In terms of stigma, it also leads to avoidance. It leads to negative things for you. They want to not be near you. So the two key aspects here are the multi-level one, because it's about societal all the way down to individual characteristics, and involves social power, because you need social power to make some of the outcomes happen. And in fact, and again, this is not universal by any means, but we often talk about public stigma, sort of like a societal kind of negative attitude, often affective or emotional, towards a target group. The sense that everyone doesn't like this particular group. And we also talk about structural stigma. That is, by its name, you can probably imagine, it's about the way in which a society is structured to deny opportunities, to stigmatize people in terms of things like getting jobs, finding an intimate relationship, having a family, and so on and so forth. And that's structural stigma. So those are the two parts. I think it's important to know right now that stigma has in fact been highly connected to health right from early on in its theoretical development. Irving Goffman in 1963 wrote the classic text on stigma. Now, if we go back to the 80s, as we ancient people do, you will recall, of course, the HIV/AIDS time and the incredible stigma that built up with HIV/AIDS all the way through the 1990s. And indeed, I've got monkeypox there. Those of us who were around in the 80s will know that there are some striking similarities between the ways in which monkeypox has been dealt with since it was declared a worldwide pandemic by the World Health Organization, and with the way in which HIV/AIDS was dealt with societally back then. But we also, from my own work, we know that people with lung cancer feel stigmatized, especially in comparison to other cancers like breast cancer, which is seen as almost a sort of the cancer of heroes, as opposed to lung cancer. But also things like diabetes, which are linked, and indeed all lifestyle sort of factors which are linked to things like obesity, which is in itself a stigmatized health condition. And of course, it's a case of not seeing the wood for the trees, because it's all around us literally as we speak. And there's a lot of COVID-19 stigma going around, and we'll sort of make mention of that. But a cursory reading of the South China Morning Post will see from time to time mentions specifically of COVID-19 stigma. Goffman originally made a lot of, and correctly so, about salient visual cues to stigma, that is, things that stood out like blemishes and so forth. And these are also often very, very linked to health conditions. But it's important to note that indeed invisible stigmas, as he termed them, things that weren't necessarily, but could be hidden, at least on the first meetings from other people, were termed to be invisible stigmas. Things like chronic poverty, mental illnesses, and on that note, in fact, in Hong Kong, there's been a lot of work on mental illness stigma, mental health stigma, by Winnie Mack and Sylvia Chen, in fact, who's here at PolyU. Why do we care? And of course, stigma matters. The OECD estimates that something like an average of about 4% of GDP is spent on mental health across member nations. 4% of GDP is a huge amount of money. And so even a small amount of impact on a situation such as that will have a massive financial and societal impact. But as well, in terms of the human cost, as we say, stigma, well, by definition, it stymies educational and social attainment of stigmatized groups. And we talked just briefly about structural stigma, but as well, in terms of my second point there, in the health area, we know it prevents people from getting help early on. Someone who's a smoker, who sees the early symptoms, or what could be the early symptoms of lung cancer, we know, because they tell us, and it's been examined, they often delay going to the doctor for fear of being stigmatized, for fear of being seen as just one of those smokers. It leads to delayed diagnoses, which often, unfortunately, lead to poorer prognoses. And again, we know that it leads to more cost for the health system later, because in terms of like prevention, every dollar spent in prevention in public health saves a large number of dollars later in terms of actual treatment costs. So what about then in Hong Kong? Well, we already have substantial evidence, as I note there, of stigmatization in Hong Kong. It's just a matter of which ones do we actually talk about first. So again, I've said there's a lot of evidence of mental health stigma, and in part that's also because there's been a bit of work, and as I'll note later, there hasn't been a lot of work in health stigma in Asia, but there's been quite a bit of work in mental health stigma, generally speaking, linking it say to Chinese cultural values and Chinese cultural variables. There's a reference there that you can sort of look up to begin with, but Chen, Mack and Lam found quite an impact of culture on stigmatization and on the after effects of stigmatization of mental health, and indeed as stigma as a barrier to help seeking. One study managed to find a sample of people who were measured both in 2001 and 2017, the same people who experienced mental health stigma. And in fact, the sad thing is that there was very little change in the experienced health stigma that these people felt across 2007, across those 16 years. Quite a lot of stuff occurred in those intervening 16 years. It's quite remarkable that there was so little change. I've already mentioned there's already evidence, both in Hong Kong and the mainland, of stigmatization on the basis of having had COVID-19. There's both academic papers. There are so many academic papers that there were already systematic reviews of it, and there are also plenty of examples in the more mainstream press. So I guess what to do, and I'd subtitle that "What to do in Hong Kong" in terms of what I'll be talking about after. But the thing is, stigma is often addressed at the level of the target experiencing it. Now, keep in mind that stigma is, by definition, a multi-level construct. So it's occurring societally as well as at the level of the individual who's actually experiencing stigma. Now, addressing it at the level of the individual, of the target, is a very important thing, because we know, for example, that people who feel or experience stigma, if we're not careful, can internalize that stigma. And internalized stigma, we know, again, is highly associated with negative psychosocial outcomes, with poorer psychosocial adjustment, the depression, and even a higher risk for suicide. So I'm not here to say we should stop doing that. I'm quite the contrary. I think we should do more of that. We should also do more of this, which is, according to my approach, which is to try to understand the social and cultural fundamentals of the system that gives rise to stigma. It's not, it's tempting to say we're trying to get the stigma at the source, but there is no one source of stigma. Stigma is present within a social system, as I'll soon show you in terms of the process. But what I'm trying to do is try to establish what some of the more social level and cultural level variables are that facilitate the rise of stigma, so we can indeed make use of this in combating stigma later. So this leads us then to this notion of what are the stigma drivers that we're looking for? What drives the onset of stigma? Now, in terms of the literature, I think it's fair to say that we've made a lot of progress in terms of the research questions such as who stigmatizes, who's doing there. And again, mental illness stigma is a well-researched area, less so other areas of health stigma. But in mental illness stigma, Pat Corrigan and his colleagues in New York State for years have been examining this, and he's come up with what's known as the attributional model of mental illness stigma. People who tend to stigmatize, pardon me, I hope you didn't hear that, tend to be the ones who attribute personal responsibility, who attribute the cause for a person's mental illness to themselves, to the person themselves. It's their personal responsibility. They've done it. They've made it happen. They tend to be the ones who stigmatize. There are other models, definitely, but there certainly just isn't the time to be going through them in this talk. The point, though, is I think we've made much less progress in terms of research questions like who will be stigmatized and why will they be stigmatized. And to my mind, if we don't forge ahead in those areas, we're never going to be able to try to sort of capture the birth of stigmas and to try to kind of deal with things as early as possible using the appropriate social processes. So we've got great models of how stigma plays out. I'm going to show you one in the very next slide, but less in terms of what drives it in the first place. So Lincoln Feeler, kind of after Goffman's work and a lot of the work that occurred in the intervening 40 years, have got probably the most influential model of stigma, and it's a sociological model, more or less, that makes use though of I think of a lot of the sort of cognate disciplines that have been studying stigma. So on this view, we sort of start with essentially like a large societal mainstream in group that we could all be a part of. However, there are certain attributes are noticed. They come to people's attention. They're noticed, and if there are, and this could be just simply being a person who suffers from a particular condition, a person who's obese, a person who has evident mental health concerns, and so forth. These are human differences. They may lead to the formation of one or more outcomes. So far, this is fairly straightforward stuff. However, it's not just random. There are dominant cultural beliefs that give rise to groups being outgroups. And it's important to note that we're talking about group identities here. We're not talking about an aggregation of persons who happen to share an attribute. The attribute becomes the identity of the group. And of course, at this point, it's very easy to link outgroups to negative stereotypes. Now, right now, what we've got is mainstream social psychology, and especially social cognition, and certainly areas of social linguistics and other areas of sociology speak a lot to this part. We don't have stigma yet. We've just got kind of stereotyping and prejudice. I mean, this goes all the way back to the work of Gordon Allport in the early 1950s. The ingredient is indeed social power. Social power. So powerful groups have the means by which to maintain the stigmatizing process, to keep it going. And indeed, it's from that process that we get to the outcomes, the avoidance of the stigmatized, the status loss, and other sorts of unequal societal outcomes. And that's what stigma is. So in a sense, it's sort of saying what we really need to kind of get a grip on are these things, the human differences that are noted. Why are they noted? Which ones are noted? And what is it that helps us, that facilitates this process of forming to be stigmatized out groups. And then what are some of the dominant cultural beliefs? What might some of these, how might these beliefs be organized, and how are they dispersed societally? That gives rise to this process. And this is, I believe, an interdisciplinary sort of topic. And this is, I believe, a topic that can't be addressed really just by one subdiscipline. We kind of all need to be looking at this from a broader social science point of view. So turning then, shifting things slightly, and now saying stigma drivers, like which differences are noted and why? Why do these things become stigma drivers? And in this connection, my colleagues and I very recently published a paper study with I think actually just over 2,600 people. We got a bunch of people and selected a range of stigma targets, groups that were already stigmatized, and had them rated and judged on a large selection of stigma relevant attributes, things that were tapping into public stigma and structural stigma and other things besides. I promised I would not go on at length about this study because it's a multi-level design that gets into some very murky and complicated stats fairly quickly. So I'm skipping gaily along, and I'm giving you the key outcomes from this particular study. What we found, there are a range of different reasons, but when we stigmatize, one of the things that we do that's a key dimension is that we use immorality as the dimension of judgment. So the groups aren't just different, they're immoral. Stigmatized groups tend to be immoral. They're not, or perceived rather, as immoral, not just different in terms of health, not just sick. The other thing is that stigma targets are actually differentiated based on morality. And we were able to do this because we were able to use the multi-level stats that allow us to do both of these things at once. And so the stigma targets, so the groups that were highest on immorality, and we used well-known targets, people people who were labelled as, say, drug addicts and certainly sex offenders, and some of the most stigmatized groups in society. Those who were highest on the immorality dimension elicited disgust, anger, and contempt. Not surprisingly, it's no coincidence that these are in fact the emotions associated with public stigma themselves. So this leads us to this notion of moralization. That is, and I'll just briefly say, so when a domain moves from being guided by mere preferences to moral rules like ouughtness, it's been moralized. The classic is, of course, smoking in the US. I may have a preference for a particular type of chocolate, that's fine, but if I choose to smoke a cigarette, especially in front of children, I'm essentially committing a moral transgression in societies like the US, the UK, and Australia. And it's associated with thinking, and statements like moral consequences happen to those who deserve them. It's not just a random thing. So why this is relevant is that in terms of health stigma, until recently, and especially in terms of mental health, there's been a lot of focus on the idea of personal responsibility as being the sort of the key driver of stigma. But I'm arguing that in fact moralization also plays a big role, and in part based upon my work with lung cancer patients and their carers in this paper. The thing is, if you wanted to stigmatize a group, morality would be a really efficient and useful way to do it, because moralization, moral judgments are fast, they're intuitive, and they're culturally shared. So they provide an excellent means, by an excellent set of processes by which this can occur. But naturally, although it all seems fairly straightforward at this point, there are going to be issues. So the thing is, if we here in Hong Kong, well, I certainly already believe that the policy and programs towards stigma should incorporate moralization. However, there are two problems. First of all, there's a lack of a coherent model of health stigma in Asian cultural context. Again, aside from the notable work on mental health stigma that's been done, there's very little work on health stigmas generally with Asians, and I put in parentheses there, in Asia. If you search this topic up, you find that when papers contain the word Asians in the title, it's usually in conjunction with Asian Americans and Asian Australians and so forth. That is a lot of work examining populations of Asians within a larger non-Asian society, but much less work on health stigmas generally. In Asia, there's some work on cancer stigma, definitely, but it's not of the model building sort. It's more of the descriptive. There is certainly cancer stigma in Asian populations. The second problem is that if we're going to be incorporating moralization, though, well, morality is strongly affected by culture. We know that. So how do the two things link up, and where do they? How do we apply the evidence regarding morality and moralization in an Asian context if we haven't actually examined it in Asia with respect to health stigma? And therefore, that's why I'm going to present this work to you this evening. So this is a mixed methods project. It's one of a couple that we're running. This one in particular, I'm comparing populations from Hong Kong, the Philippines, and Australia, and obviously on health stigmatization and its predictors. Now, I've put there moralization and not versus personal responsibility. Again, I'm not here to deny the importance of personal responsibility. It's always bothered me when academic studies are sort of pitched as like a battle to the death between two constructs. I strongly want to put forward the importance of and the role of moralization in these processes beyond simply the more obvious applications. I'm not here to say that personal responsibility does not matter. We did this. We've got to do this in multiple ways, because you can't just approach stigma, I think, from a single sort of discipline point of view, and you can't use a single sort of method or paradigm. We did, first of all, an interview study with native, non-patient, that is general public respondents. And we were trying to understand which were the conditions that were more stigmatized in each culture, because that in itself tells us something about the nature of stigmatization in that culture. And in a connected way, then how we enact stigma in each of these cultures, looking, of course, for both commonalities and differences. That is then going to feed into, it does feed into, the second part, which is the survey study, an online survey, again with general public samples, where we're testing effects of moralization and personal responsibility variables in conjunction with what we've gleaned from the interview study. So I'll start with the interview study. The question here is what are that we use to actually start the discussion of what are the health conditions that change the way you feel about someone. I've got in there in parentheses others, because some respondents, especially the Australian ones, didn't feel comfortable expressing their own personal stigmas. And this is an issue with respect to understanding stigma. Stigma, the process of stigmatization, kind of ironically, given that it's occurring societally and that we know it happens and we know it has negative outcomes, people don't want to be seen to be actually stigmatizing. And this is especially so, I think, in some cultures than others, and it's its own talk. In fact, we've got data on this, but I can't talk about it. But there's no time to talk about it now. It's not that it's secret. So we said so the interviewers, if they really couldn't get the person to say anything with respect to the first phrasing of the questions, we sort of changed it around and said, well, if not you, then how do you think others in your culture might feel about someone, etc. And that often just basically allowed the floodgates to open, and people gave us much stigmatizing content then. And we did an initial content analysis just to identify the conditions with respect to that first question we were looking at. We then followed up, and this is ongoing, with a thematic analysis to identify the more health stigma relevant themes. And we also looked at attributions, but again, this is not I don't think there'll be space in here to talk about the attributional side. Now I'm keeping, I beg your pardon, I sort of tantalized you there with a table, but just in the interest of time, I'm not going through every single detail about these things, but I can certainly talk about them. I've tried to leave time for questions. So I'll just play on. I just thought people would like to see at least some of the conditions that were nominated. You can see there that indeed mental health and related disorders are well represented. These are essentially the top 8 or 9 conditions put forward by each sample. Yeah, mental health is well represented there. And now we've tried to use wherever possible the terms that were actually used by our respondents. So if they tended to say things like mental health, we've used mental health. Interestingly, for example, in the Philippines, HIV and AIDS were talked about separately, whereas in both, it wasn't mentioned at all in Australia, and in Hong Kong, it was almost always mentioned in terms of HIV/AIDS. So we've made note of all those things. You can see mental health is well represented there. HIV is certainly well represented, at least in the Philippines and Hong Kong. Autism pops up, also cancer. So a number of these conditions, you can already tell, will have, it's not difficult to already, I guess, potentially infer some of the potential moralizing links there, but we've looked at them a bit more specifically. So these are some of the most, I guess, the most relevant things from the analysis that we're doing. Again, there won't be time to go through the entire thing, but I thought I'd actually focus in on the moralizing part, because there's a lot of evidence of that, and I had to really restrain myself from putting forward lots of quotes from transcripts that sort of linked in, to that. So what we found in Australia, to use this as a sort of baseline, because a lot of the stigma research has been done in English speaking samples, there was an emphasis, as I say here, on the personal morality of individuals, and not just the personal morality of individuals, but as you'll see with respect to things like harm and fairness. So this person said, look, people that make particularly bad choices health-wise, they chew up the health system, whether I say children that need healthcare, who are put on waiting lists because there's not enough for ambulances, needing to go out to someone who has overdosed on drugs or completely drunk into a stupor. And there are children with breathing difficulties that can be helped, and that kind of stuff. So this person's clearly making a moral judgment, a moral summary of a person who, and again, it should be noted, has taken what appears to be a personal choice to use drugs or to become drunk. But it's not just a personal choice, it's a personal choice about a highly morally relevant action. And what they're doing is causing harm, and it's posing a challenge to fairness. And these are the themes. We know that these are the themes of morality in English-speaking cultures. And there's been a lot of work in recent years, in particular, looking at morality in the US and related places, and things like harm and fairness play a large role there. So this is a particularly fitting sort of comment. Now, the contrast here is quite marked in terms of, say, Hong Kong, and this is quite a representative quote. The locus of stigma here, not surprisingly, was on the impact on the family or the network of friends, that is the close network around the person. This person's speaking about people with autism spectrum disorder, ASD. Firstly, they are very closed to themselves, and then others do not want to be close to them. They do not want to be close to other people either. There's no way for them to conduct normal life and study. It's also harmful to other people, especially their family members. If they must be sent to the hospitals, some families will also have to bear considerable financial pressure. Then for themselves, it's not necessarily to be sent to the hospitals. People in society will look at them differently, and they may not be able to get treated even in a hospital. So there's a lot of so the big distinction here is that instead of, and again, this is a moral judgment, because it's really talking very much about what they should and shouldn't do. The big difference here is that instead of an appeal to a personal morality that ought not to lead to sort of to unfairness and violations of justice and so forth with respect to sort of others, it's very much a sort of a transgression, because it affects the family so negatively, and the person is in some ways being selfish in causing this sort of impact upon their family and network of friends. And this focusing on the family and the network of friends as the receivers of the immoral actions of people with different types of health conditions was a feature of this data. But by contrast, again, in the Philippines, and we go back to a sort of personal morality, but in this case, instead of it being like a morality that alludes to the possibility of doing harm and being unfair to others, it's much more directly rooted to a sort of I guess a sense of purity, and it's an individual morality with a direct linkage to sin. This quote, for example, that's like this person who belongs to a professional field and was found out to have chlamydia. It's just chlamydia, right? It can be treated with antibiotics, but people still have very lasting, like, and even if you're already cured, the rumors will still be there. It's a lasting impression, and like people see you as your disease and not beyond like his or her qualifications. And in fact, there's another quote that I was really sort of juggling about whether I should be showing it. The person says, look, this is the Philippines, and the Philippines, the conditions that are going to change the way I feel about people are those that link you to sin, that mean that if you've got them, you must have been committing sins. That's what happens in the Philippines. So that's sort of this really, the three clearly all about morality, but all focused in on a different approach is really one of the themes, one of the overarching things that we've got here. Now, I just wanted to sort of note that in fact, personal responsibility was not absent in these transcripts. Like sometimes people, and this quote here, for example, from an Australia, and sometimes people might see some diseases like diabetes as self-inflicted, so they might have a bit of prejudice against, like, if you didn't eat so much sugar, or if you weren't so overweight, and be judgmental about that. Now, this is a personal choice to eat too much food. That's what's being referenced here. But again, I would put to you that there's quite a moral overtone to the way that this is put forward. It's not just doing anything. Whereas in Hong Kong, for example, a friend, you see that his health is poor, but he has bad habits that he's not changed. Like, tell him not to smoke so much or drink so much alcohol. Help him to recover. So again, it's not that we didn't see personal responsibility. We did. Also, so quite a lot of morality and things that were relevant to moralization. So I think it's fair to say people do use moralization in stigmatizing judgments about health across cultures, but they're enacted differently. And people also do refer to personal responsibility. So the next logical thing to do is to follow this up in our online survey, and we used the selection of conditions from the interviews. We had an overall sample of about 1,400. Each participant only saw one condition. We didn't want to overburden them with heaps of judgments about lots of different things. And we were really looking for their judgments of the stigma targets. All the people in this sample, well, none of the people in this sample had taken part in the interviews. They were a different group. And the conditions are mental health, obesity, HIV/AIDS, contagious conditions, and autism spectrum disorder, all represented in some way across. We left cancer out because we've got a whole other study about the same size as this on lung cancer versus colorectal cancer versus melanoma, and again, there just isn't time. One thing to note, so this is a general public sample, not a first-year student sample, but a good age range. Philippines age range is a bit different, it's quite low, and I think that makes a difference later, which we'll sort of talk about. Generally speaking, yes, it's clear. The Australian and Hong Kong samples came from an online data provider, and the Philippine sample we got through ads on social media. So that's certainly something to keep in mind in terms of the limitations. But so just in terms of moving here and leaving time for questions, I'll just quickly go through the questions that we asked, and I'll show you the overall model before I show you the results for it. So we asked about moralization. We had a couple of questions that, for example, in my culture, this condition is linked with moral failings. We also talked about personal responsibility. So we looked at, did you have high amounts of control over getting it or not? And conversely, was it difficult to avoid getting it? They sound like they're the same thing, but they're not. And the statistics actually suggest that they're not, but they are quite linked. So we use both of those. We looked at then perceived structural stigma and perceived public stigma. As I said, there are these two sort of levels of it. And looked at, would a person with this condition have difficulty getting a job or difficulty finding a relationship? And for public stigma, we kind of went for the intergroup and anxiety approach. In my culture, most would feel about a person with this condition threatened, angry, disgusted, and a whole list of other negative intergroup emotions. We settled in on these as being the most relevant, and there are other reasons to do with measurement invariance that I'll talk about. And finally, we needed to have an avoidance outcome. So we used close social distance, which is essentially the opposite of avoidance, but it's keeping people close rather than avoiding them. Imagine someone with this condition, how would you feel about, and there are about 5 or 6 items. Some of them are things like renting a room in your house, having them look after your children, working on the same job, and so forth. So those are the variables. We also controlled, and I won't linger on these, but we controlled for things that we know have an impact on close social distance to make sure that we were above and beyond what these variables can explain. We were looking at the impact of stigma on the avoidance variable. Now, this is the model. So on the right-hand side, you can see there's the close social distance. We made the two types of stigma, the proximal predictors, right next to it. And then we basically are setting this model up. It's a simple model. We're allowing personal responsibility and moralization, respectively, to be potential predictors of both types of stigma. And so implicitly, anything that we find for moralization is above and beyond the effects of personal responsibility, and vice versa. They're in the same model. So if we find effects for moralization, we can implicitly say, despite the effects of personal responsibility, we found these effects of moralization, and vice versa. So I think it's important to note that for people who aren't necessarily, who don't look at quantitative surveys a lot. So again, the technical side for those for whom this matters, and it's an important thing. So we achieved the magical scalar invariance for Hong Kong and Australian samples, which means that statistically we're able to say that we're sort of measuring the same thing in terms of all of the measures. Philippines, I showed you the sample, the age issues, slightly more problematic. So we're having to kind of deal with that. However, I've rerun all of this as keeping the Philippines completely separate in its own sample and running what's called a multi-group structural occasion model with Hong Kong and Australia only, where we did achieve the invariance. And when you compare those, we actually get extremely similar results. So I'm quite confident in the results that I'm going to show you now. So this is the impact. So first of all, the model fits. This is a structural occasion model run in a multi-group format with Philippines, Hong Kong, and Australian participants treated as three separate groups within the overall model. There are the fit indices, CFI, gamma hat, RMSCA, and so forth. Now, it's always annoying to look at estimates for multiple group models on the same model. So I apologize there. And also, for those who are used to looking at these models, these are all standardized estimates to make sure that we can compare the numbers across parts. So the Hong Kong parameters are in bold, Philippines are in italics, and the Australian ones are in standard text. And I've got them pretty much in the same spatial disposition for all of the parts. These parameters are regression parameters. There's no theoretical maximum, but 0 means there's no relationship between the things. The higher they get, certainly close to 1 is a big relationship in standardized ones. The higher they get, the stronger the linear relationship. I don't know if you can see my arrow there, my pointer arrow. Hans, can you nod if you can see my pointer arrow? Excellent. So, for example, when we perceive there to be high levels of public stigma towards a condition, there's a negative relationship to close social distance, which means higher levels of public stigma associated with lower levels of close social distance, which means avoidance. So we want to keep them further because we don't want to keep them close. Similarly, for perceived structural stigma, higher levels of perceived structural stigma associated with more avoidance because it's less close social distance. And this is true in all three samples. Incidentally, all of the parameters that you'll see here are statistically significant. They're different from 0, except for one case, which is noted. So first of all, this makes sense. Stigma does lead to avoidance in our sample. When we perceive there to be stigma towards a certain health condition, we actually want to avoid them ourselves. Now, let's look at the predictors of structural stigma. We've got personal responsibility, and we've got moralization. So personal responsibility is a reasonably strong, fairly strong predictor of perceived structural stigma, but it's negative. Now, this means the more controllable and easily avoidable a thing is, the higher the personal responsibility, the lower the perceived structural stigma. And this seems contradictory, but actually it's not, because what it's doing is it's saying, if we think a health condition is subject to high levels of personal responsibility, that a person can easily avoid it and doesn't have to have it, we actually don't think they're going to experience a lot of structural stigma. Now, this The irony, though, is that this can be seen, this minimization of the stigmatization likely to be felt by someone is in itself a form of stigmatization. Because if they kind of brought it upon themselves because they didn't avoid it, well, they're not going to suffer too much. And so that's what this part is actually showing. By contrast, moralization, the more moralized a health condition is, the more we actually perceive them to be suffering structural stigma. So that's again, a fairly strong, maybe not quite as strong as personal responsibility, but it's a strong enough relationship, and it's positive. More moralization, more structural stigma. Looking now at perceived public stigma, now this is the generalized public attitudinal kind of response to a health condition. Now, if we look at personal responsibility, well, now it is a significant predictor, but it's quite a bit weaker. And in fact, in the Philippines, it's not significant. And in Australia, it's not particularly strong, but it's there, a bit stronger in Hong Kong. So again, it's negative. The more that we think someone is to blame for their condition, the less perceived public stigma we think that they feel. Instead, if we turn now to moralization, well, now we've got a very strong and again, positive relationship. So the more we moralize a particular health condition, the more public stigma that we think that they're going to experience. And what's notable, of course, is that as with all of these, then therefore, the more avoidance that we're going to show towards the people. If we judge their health condition to be moralized, we think they're more stigmatized, and we want to avoid them more in turn. So just one last shot there with all of the parameters there. So what this is telling us is that personal responsibility does work. It is a predictor, but moralization also works, and it's quite a strong predictor, especially of the attitudinal public stigma components here, but also of the structural. So I said I'd try to leave time for questions. So I'm in my last couple of slides here. So we've got, what this is telling us clearly then is that moralization and personal responsibility, we both need to be, we need to be dealing with both of those to actually reduce stigma. We've got, for example, if we want to change public attitudes to members of stigmatized groups, we've got to deal with the fact that moralization is playing a big role in those processes. It's not just general attitudes, it's their source appears to be the fact that we moralize the health condition to begin with. So we have to understand what that means. And this, I think, is also relevant to stigmatization beyond health. I think our previous results show that the extent to which we moralize a group of people, and there's other evidence for this, really will have an impact in terms of our negative attitudes towards them. But conversely, if we want to do something like convince the public that spending on stigmatized groups is worthwhile, and for example, research spending on lung cancer, despite its the high numbers of people with lung cancer, one of the most prevalent cancers in the world, is much lower than for things like breast cancer or of course certainly colorectal cancer. And that's a form of structural stigma. If we want to convince the public that we should spend money and not structurally stigmatize some of these groups, well, we need to think about the personal responsibility part as well. We can't just choose one and not the other. There's an elephant in the room. There are lots of other excellent pictures of elephants about, but this was the sort of one least likely to get me into trouble. And the thing is, we're all sitting here in Hong Kong. Now, a lot of the work on moralization, things like that, has occurred in other cultures, especially in the US. So the thing is, what exactly is moralization? We know that if we moralize, if we think that a condition is basically very linked to someone's moral standing, it makes a difference. But what does that mean? And what does that mean across cultures? We don't actually know what moralization is and how it works. And so, of course, this is the subject of future studies that are planned, hopefully be funded too. But that's clearly the main route, I think, to go down here. But some other questions that I think are important and broad-based. You know, we need to sort of ask, like, as I say here, what does a health condition actually communicate about a person in different cultures? Like, what is it telling us about who they were to get it in the first place, who they are now when they have it, and of course, who they will be when potentially they will no longer habit. People are living longer in most parts of the world, and they're living with diseases that generally will have either remitted or will have been cured, and they see themselves much more as potentially survivors of these health conditions. And we don't really know enough about the communicative aspects of this. We also know, and I sort of alluded to parts of this, but there just wasn't enough time, I think, to show more of the evidence. But health stigmas, of course, can be expressed using more indirect linguistic modalities, and including hedging. And we're looking at hedging as another part of this actual project. But so, given that, I think there's really fertile ground for linguistic constructs, both as markers of stigmatization. I think it's important, and that are really relevant to again to cultural processes of communication, but also we need to look more at linguistic constructs as ways to communicate things like destigmatizing beliefs and attitudes. So, for example, I think there's a lot of work that could be done looking at, say, cancer survivors and the societal adoption of the battle metaphor. And there has been some work looking at the battle metaphor, but its impact upon survivorship and upon people's experience within a society where that's a really prevalent sort of belief. So I guess that's an example of the sort of thing that I think now we can boldly go forth and really spend much more time addressing in an interdisciplinary way this and other questions. And so with that, I show you the references briefly, and I thank you.